Hi, everybody. It's Kevin and it's Donna, and welcome to another episode of the Med List. Donna, how was your weekend?
Weekend was good. My sister's up from Florida with her family, so I have a very full house.
Oh, nice.
Yeah, from 6 to, I won't say how old I am, but yeah.
No, 39. Yeah, I got it. Got 6 to
Yeah.
39. That's perfect. No, we did a similar thing. We got together with family. We went down and my sissy pharmacist hands. It used to be tough at one time, I think. No, maybe not. But I was building fence, and so I've got some blisters on the hands from doing that. And it's great
Yeah.
to work beside my dad, who's in his 60s now,
Yeah.
and just seeing him work and just maintain his physical abilities, and that's really awesome to just be part of that kind of family atmosphere. And
Yeah.
so talking about the subject we're talking about today is really, near and dear to the heart. I got to talk to my grandma Walker just this last week, which was wonderful. And she's in her 90s. And she's doing fantastic. I mean, just mentally sharp as a tack. But
Wonderful.
sometimes for some families, that's not the case, Donna. And then we have to rely on the system known as long-term care. And right now, our country is wildly overburdened, with what's going to happen next in that space. How are we going to take care of an aging population? And so, if anybody listening has family getting close to that area, if you yourself are getting close to the point where independence at home is a concern, then you're in for a really good episode. So I hope you enjoy. All right, we'll get started in a second. All right, bring it on.
Yeah. So I'd love to introduce today our guest. We have Dr. Courtney Myers with us, Kevin, and just love what you're doing, Courtney, with your background as a board certified geriatric pharmacist and consultant pharmacist for Absolute Pharmacy. And it sounds like there's so many different types of areas in which you are a consultant, long-term care and post-acute skilled care, assisted living, intermediate care, also facilities where you're helping the mentally disabled as well. So many different areas that you actually work in. And I'm thinking about all those families out there that have somebody that they might know or somebody in their own family who might fit into one of these categories, at least at some point. And I also want to mention that you also have your own company called Complete Care Consult LLC. And I just love what you're trying to do in this space too, and really trying to have pharmacists become available for patients in all of these areas, not just long-term care where we are allowed to actually consult, but actually all these other areas and actually get billed. And isn't that an important feature that we can practice clinically? So I would just love to hear more about you, a little bit more about your background, and just if you could give us a little bit of information just to start us off with what you're doing and where your company might be going.
Mm-hmm. Yeah, thank you guys for the introduction. So I've been practicing in the long-term care geriatric space for almost 10 years now. And it's primarily in the long-term care sector where I'm going in and out of facilities doing med management and chart reviews for residents who reside in these facilities. And I know that these are your very clinically complex patients that I typically see. A lot of medical conditions, see a lot of specialists, a lot of different providers going in and out. And we just kind of go through their charts to make sure their meds are aligning with the conditions that they may have, as well as different, like their goals of care and quality care, and some of their life goals as well. My complete care consult just kind of stemmed from wanting to do a little bit more for the residents that I see. In the space that I currently work in, you're very time limited for what you have to work with, and it's unfortunate. It's just the way that the system and the system is built, the structure of the whole model is. But Complete Care Consult just kind of stemmed here in Ohio that we were able to receive provider status. So being able to bill directly for our services instead of burdening the facility to utilize a pharmacist in their building. And so I'm just kind of using Complete Care Consult to help assist with figuring out how a pharmacist can redo their structure and their model in the long-term care space, to provide quality care for residents, and see how that can kind of develop and mold and form, getting reimbursed for the time that you spend. And then I'd ultimately like to see this model push into like a long-term care at home. One of the things that I do feel that is missing in just in our culture and society in general is efficiently and effectively allowing the elderly population or older individuals aging the way they want to age in their own home, and then providing tools, resources for that. I know that there is some stuff in place, but I feel like there's certain things that my patients in the long-term care space have access to and that are done very consistently because it's regulated. And so it's a regulatory piece that may not be happening in the community type setting.
Yeah. And Courtney, I have to add that, and I'm sorry I neglected this at first when I introduced, but that you were also awarded a 40 under 40, I believe, of innovators in pharmacy. And just what you said, and thinking about this whole, long-term care at home and how important that is, but getting pharmacists there too.
Mm-hmm.
And what is that model going to look like? It is so important because long-term care, we do know that pharmacists, and maybe not everybody knows this, but pharmacists do need to review patients' medications in long-term care. That is one of the standards of care. But if you have somebody living at home and that you're caring for them as a caregiver, you do not necessarily get that care available to you that can be reimbursed to the pharmacist that is doing that work.
Mm-hmm.
So such an important point of what you're doing there. So I already love your innovation, and I'm sure you have so much more that you want to talk to us about too. But I just think that is a really important thing that people realize, that there's these visiting nurses associations that they might have access to. So you have nurses, you might have PT, you might have OT available to you, but you do not necessarily have pharmacists within those groups because pharmacists are not reimbursed currently in that model.
And to kind of piggyback what you had mentioned there, I also think that some of the long-term care placement of some of my residents could have been even prevented if their managed medications were looked at a little bit sooner, a little bit quicker, because as your body ages, in my space, as you get older, everything slows down. So your medication should be reflective of that. And oftentimes they are not.
Yeah.
So, and then stuff starts happening in the home, and it could be medication related, and then it might end up in a long-term care stay,
right,
for a hospitalization or something else happening. And that's kind of where I want to insert a pharmacist to help prevent that from happening.
Yeah. Great point. Me too.
Yeah.
Kind of my MedStrong goal. So we're on the same page here. No pun intended.
On the same page. With that, Courtney, you mentioned pre-show that one of your goals and kind of hopes is to allow people to age the way that they want to, right? Mm-hmm. Overall. So what have you seen that inspired, I guess, the business overall that would allow people to age more often in their homes when it comes to medication management? Like, what are some real quick takeaways that someone listening and they're just like, I have 10 minutes to listen to the med list today, and they're like, I want some heavy hitters right here. What are the things they can do at home to be able to help themselves stay out of the long-term care setting when it comes to medication management?
Oh my goodness. I just had a thought, and it came and went. Don't be afraid to ask questions. Big thing. And if you feel like something's off, don't be afraid to explore it, because usually your gut instinct is the best instinct. And be active, stay social. People forget the social piece of it. Stay active, be social, drink plenty of water.
I love all of those. So let's say we tried all those and we were really hoping we could stay at home, but things just got more and more complex overall. And now we ourselves or a family member is going into a long-term care setting. I feel like transitions of care, for anybody unfamiliar with that term, it's usually if you're going from the home to long-term care or to a hospital setting, or basically moving from any area you'd receive care typically to a new area, right? And or back. So when it comes to that transition from home or from a acute hospital stay to long-term care the first time, my experience has been lots of confusion and frustration from the family, right? Of just like, how are mom and dad and or uncle being cared for in this setting? And what are the new expectations? How do we level set there? What's your advice for the folks that have just entered this new setting on how to get things started off on the right foot?
Yes. The process can be overwhelming, and that's normal. There is a lot of new terminology. It is a new language. I tell people that if you start diving into a realm you're unfamiliar with, it is a new language, and you have to learn all new language. And as you get older, sometimes it's harder to understand and comprehend. You can get anxious. That's normal, and that's okay. A lot of people experience the same thing. One of the big things is make sure you have an accurate medication list. That's crucial, whether you get it from your pharmacy, your doctor's office, you keep it at your house as you transition. That is the number one thing. Get as much detail and as much information as you can, as well as like your primary care doctor's information. Oftentimes your facilities will have a doctor or a medical director that already comes and visits their facilities, and a pharmacy that's already contracted with the facility. And that is absolutely normal. Always remember that you as a patient always have rights, and you have the right to choose. And making sure your goals of care align with the treatment and the treatment that you're receiving at your facility. That goes with medications, things that you want, don't want done. So that comes to advanced directives and your will, having a designated power of attorney. There's a lot there. A lot of times people may not have that done yet. I've seen that quite often. Right. And there'll be a lot of information, a lot of pieces being thrown at you, but don't be afraid to ask questions, call the facility, and just understand that it's a learning curve for both people, for both parties, the facility and yourself, because the facility is going to be caring for your loved one. And that is going to be a new experience for them because everybody's different, but the facility recognizes that.
Awesome.
So if you could, talk to us a little bit about some of the successes you've seen and what you've done in some of this like innovation, if you will, or, just some story that, where you really were part of somebody's med list, changing that, or being able to bill accordingly. Is there something that you could share with us in that regard?
So there was actually I have two instances. There was a patient was in her room, just kind of resting and relaxing pretty comfortably in her bed, and her daughter was with her. And they were complaining about, I do a lot with bowel movements. I do a lot of bowel management and bowel care. She wasn't overly satisfied with her bowel management or bowel care at the current time. And in discussing with both the patient as well as her daughter, we were able to kind of narrow down maybe some of her medications that could be contributing to her bowel issues, and taking off some of the medications that could be contributing to her being a little bit more constipated, and then also adjusting her regimen so that she got a little bit more comfortable with these regimen. There's that instance. There's another instance when I was working with one of our physicians, and he was looking to add on a pain medication, and the family members were concerned about cost. And so in talking with the physician and the family, the one thing I always have to bring up is that oftentimes it's your insurance company that dictates costs, so the physician wouldn't be able to know until you actually bill. But if it comes back at a certain price, I would be able to step in and assist. Well, we can go through your formulary. We can see what would be the more preferred agent. It would be a little bit more cost effective for your situation. So in having some of the cost containment strategies with family members face to face in resolving those issues, kind of taking some of the pressure off of the physician, relieving some of the stress of the family, assisting the pharmacy, and kind of being the intermediary in between the different parties.
So really, you're really right there with the patients and with the caregivers and talking through issues. And I don't know if how common that is. Do you think that that's some unique practice that you have in what you're doing and in the homes where you are? Or do you think that that is pretty standard across certain types of clinical work?
So in my long-term care facilities, when I go visit my residents, oftentimes I don't see the family members. It depends on what time their visiting hours are, when families kind of come and go. If they want a special request to meet at the same time, I do try to accommodate. I kind of give them a range of the date and times of when I'd be there to see where our schedules could align. Um, Sometimes, or actually oftentimes, it's just random that I run into them and we by a chance cross paths. But more often than not, in the long-term care setting, I don't run into a whole lot of families, but I would like for that to kind of expand, because I also learn a lot about then the patient. I learn a lot of little nuances that I make notes on, and the things that they really like or they enjoy, what they valued in life or what they find important to them, so that I can customize their medication regimen to their loved ones so they feel like we're doing everything we can for them.
So, Courtney, I also know that you have mentioned, like, you've done this like antibiotic stewardship for some of your homes. And I think that that is something that as pharmacists, we know that that happens in hospitals and, of course, like long-term care homes as well. Hearing you talk about bowel management was piqued my interest a little bit, because again, I understand, like, as a pharmacist, that that is definitely a side effect, or or you go for a health visit and you're asked some of those questions, but I've never really heard anybody say bowel management. and and so with that, I guess I'm just curious, is that again something that is like a, a constant across all um, consultant pharmacists, that is one of the factors that you're looking at? So anyone who is in long-term care, anyone who's caring for someone, they could actually say, oh, I want to talk about bowel management, or is this something unique compared to what you are doing?
So just like with any of your like physicians and providers out there, every provider you come across will have like their little niche, the little things that they're good at, the little things they have a passion for. If you're looking at a geriatric pharmacist, there's a whole spectrum of syndromes that they kind of coin off as geriatric syndromes, just common ailments that affect an elderly or an aging population that majority of your consultant pharmacist could touch on. Now, the in-depth of the scope can vary from person to person based on experience. But in general, majority of your geriatric pharmacists would be able to assist with that. Even a lot of your typical pharmacists could even help with that. With bowel management, there are a lot of products out there, but they're not that vast compared to some of your other conditions you might have.
Yeah.
But yeah, that is something I like to touch on. That's something I do a lot of, is bowel management, especially in our older population.
That's great. And I think part of what I'm trying to get at too is that you mentioned it. There are a lot of syndromes, geriatric syndromes, and these are things that people love to blame on age, when it really could be the medicines that they're taking. And I think that that's such an important factor, that when we're talking and interviewing our patients or caregivers, when they're with their loved ones, or providers in general, if someone's complaining of various things and blaming it on age, I think that's a red flag that we better start looking at the meds and seeing if we can take care of that age problem when it really could be just one of the meds that they're taking.
And majority of the time I take meds off. So the big thing now in pharmacy is medication optimization. And one component of that is deprescribing. So I do more deprescribing than putting medications on. So it's very helpful. I take a lot of stuff off. That's what we look to do.
I feel like there's something that can get minimized when it comes to bowel management, but we see it with hearing loss and we see it with bowel complications, that oftentimes that will stem into a number of other things, Courtney, that families and clinicians have to be aware of. That you have a patient, and you please give us some patient stories here. You have a patient that has a bowel management issue. Constipation oftentimes hits in later years. And now all of a sudden you're seeing them stop eating as much. Now all of a sudden you're seeing them have behaviors that pop up, or pain management is not working as well. And so when we have family members that are there, that are constantly watching, like, this is my typical, expectation of how mom and dad are doing, They have a better idea when it comes to some of those nuanced elements of our care that maybe on first blush we're thinking, well, it's just a bowel movement, right? It's okay that we're missing now 2 or 3 bowel movements a week, when that can precipitate into some really significant problems, or mom's hearing or dad's hearing has gotten worse. Now, all of a sudden, their aggression is worse. They're taking more over-the-counter medications to be able to help with sleep. They're now not participating in social activities as often as you mentioned as being a major factor. What other things, Courtney, can you kind of open up some folks' eyes when it comes to your family is now in the setting or you're in the setting, and some things that get minimized, pretty quickly, or as Donna, worded it, they get attributed, to age alone. Well, that's just the aging process. Other things that you can think of that folks should be aware of?
So as you get older, things start to present atypically. So you'd expect things to present a certain way, but then it doesn't. Mm-hmm. So as you get older, you'd expect something to present, I can't even think of a specific example off the top of my head, a certain way, but it comes out with a super generic confusion. Everything's confusion. Everything's delirium. Everything is just a little bit off. And that is the big symptom that red flags me is, what are our medications? It doesn't take much as you get older, especially when your body's normal processing system, everything goes through like your kidneys or your liver. And that's where your big drug metabolisms and elimination pathways are. So if that's all slowing down, then your drug levels are increasing if you're maintaining those same doses. So that's an overly simplified stint. It's very overly simplified for anybody who's watching, super simplified. But if you kind of keep that in the back of your mind, that's why I always think and could be your medications, and it might just be presenting as a little bit of confusion, a little bit of forgetfulness. And then maybe family members are thinking, well, they have dementia. Is this onset dementia? Is this type of dementia? Oh, maybe they have this, or maybe they have that. And then you have like that fear, panic, anxiety, and just like you had mentioned, that cascade of events that just kind of culminates when it could have been something as simple as just a medication.
You're segueing me so well, Courtney, with your cascade phrase there. So one thing that Don and I, we've talked to folks about deprescribing and optimization often. We've talked about cascades as well. Can you talk about, you described it already, so I won't repeat it for the audience, but basically what Courtney's talking about there, you have something that starts in, you guys have heard on the med list us talk about this one thing topples the dominoes, and then things continue to cascade in the wrong direction. I think the one other interesting thing is just recently there was a study that was put out there, and it talked about med management, deprescribing, cascade avoidance during stages of life, and this was particularly looking at end of life, palliative care type of situations. But Courtney, I'm sure you have to make those exact same decisions when it comes to folks get transferred in. Maybe they're still looking at 15, 20 years of good life remaining, but there's limitations that don't allow them to be at home. How do you help families through and clinicians through the decision of what medications are needed, like still needed here, and which ones aren't? Because we're not looking to live another 50 years. We're looking at 10, 15 years.
Yes. It's funny that you bring this up because I just presented on this at the Ohio Pharmacists Association here this last April. So there's a couple of different strategies you can kind of look at. So you can look at some of those medications that just kind of stick out. So if somebody has dementia and they're on an Aricept, one big side effect of Aricept is reduced appetite because it can give you a lot of GI, like upset stomach, right? Mm-hmm. Well, and then somebody might stop eating. Somebody who's dementia might not be able to verbally express how they're feeling, so they just stop eating, right? So, well, they're not eating. Well, we need to increase their appetite. What do we use to increase appetite? We use an antidepressant, mirtazapine or Remeron, which is typically supposed to be used for depression, but a side effect is it stimulates appetite. So we stack that drug on top. So there's some snippets when I look at med lists where I find combinations where I can kind of see where I see a medication treating a side effect of a drug. Mm-hmm. And it's one of those things, it's almost like a puzzle. They just start popping out at you. Yeah. As you look at that med list, they just start popping out. And so I just start marking stuff as I see them coming down. Another strategy I like to look at is I like to separate my meds out into my critical medications versus my symptomatic management medications. So meds that are more like life sustaining, going to reduce that morbidity and mortality within like a designated like time frame. And then those medications that are just symptom management. And I usually look at the symptom management medications first. Is this necessary? Do we have to be on this? But even before I get to that part, I always look at what symptoms are my residents displaying first and what are their goals of care. So the big thing with this is shared decision making. So regardless of what I do before I do anything, as I work up my patients and I look at their medication list and utilize a bunch of these different strategies to look at and evaluate their medication list, I come up with multiple different plans that you could potentially take, and then align it with the conversation that you have with our patients to see what would be the best strategy for them and if they agree.
Smart. So that one example, can you tease that out for the audience a little bit more for both clinicians and patients? Aricept is a great example, and we're seeing more and more medications come out, exceedingly costly medications come out.
Mm-hmm.
I mean, I'm going to be a little biased here, with very poor data that they actually work, right? Especially at this stage of the game. But when it comes to a family, that's not the case. Like, that is a hope that they're holding on to, that this is going to either make mom and dad better, which we know that the data does not show that regardless of it, or it's going to maintain them right at this level. And if they get rid of that medication, then we're going to start losing some of mom or dad and or uncle.
Mm-hmm.
How do you navigate that conversation for both clinicians and patients on the decision to stop a medication like Aricept that's goal is to maintain some of that memory function?
So there's not a one shoe fits all. There is no right answer for one person. I am a firm believer that I really like to follow evidence-based medicine and clinical guidelines, but I also understand that people are dynamic, and the social and cultural beliefs of individuals truly matter when you're trying to develop goals of care. And making sure that they align, especially when you start getting to like your older years in life, that becomes a little bit more important than just medications, because you start coming to a time in your life that mom and dad might not be here in a couple years. So what is going to give them the best quality? So quality starts weighing in more than quantity of life.
Yeah.
So with your example for your Aricept, there are some medications where you can kind of measure a little bit if the medication could have benefit for you. With Aricept and looking at dementia, that'd be like a BIMS test to kind of see where you're measuring and how you're scaling. With that, if your BIMS starts to really get down there low, the medication may not be working a whole lot. And so those conversations of, would you be okay with like trialing a dose down to see how your mom and dad does? Because you can always taper down. So when I go up on meds, I go real slow. When I come down, I like to go real slow, probably slower than what a lot of people would do. But it also makes families feel more comfortable when you see that you're trying to go slow and see what happens and do a little bit more frequent follow-up. I'm all about making things comfortable. Everybody's happy with the decision that we're making, because we don't want to make anybody worse. And we don't want anybody to feel bad or feel really uncomfortable.
Right. I always think it's important too that people know, like, if you do need the med, you can always go back up if it's necessary. So it doesn't have to be scary or, oh my gosh, what are we doing? It's like what Barbara Farrell told us, Kevin, it's that pause and monitor and then see what goes on from there.
Mm-hmm.
And I love that. I love that Barbara has shared that with us. One thing I want to talk about too, Courtney, is kind of going back a little bit. You were talking about the time frame. You said that there's not a lot of time to review the files or the information on all patients. And this sounds like, of course, it's very time consuming. I think we all know that. We've all have done medication reviews, and to do it to the level that we believe is necessary and we know is necessary, it takes time. It takes a good amount of initial time, and then takes a lot of follow-up too. And you had mentioned that in consulting, it's really like limited time. And we hear that from docs too, right? That they just don't have enough time with their patients, or patients say, I don't have enough time with my doctor. So how are we looking at this in regards to consultant pharmacy as it stands right now and the timing, and what you're trying to put into innovation in Ohio um, with increasing that time, and giving that little bit of care, and or that like long-term care at home model, and being able to be that repeated consultant pharmacist. Do you
Mhm.
have some ideas on that already that you are willing to share with us?
Sure, sure. So I've been working a little with the Ohio Pharmacists Association to get kind of like my model up and running. So I'm kind of like meshing a few different things together. So I like solving the problem. I get a real big kick out of trying just to solve the problem. So in the long-term care, I get like a generous 5 to 8 minutes per chart. That includes physically picking up that chart, opening it up, searching through whatever I need to do, doing my med review, documenting, and then going on to my next chart. So that's very, very fast, especially when you have people on 20 medications. And there's all these different things, both from a clinical and a regulatory piece that you're looking at. So with pharmacists having provider status in the state of Ohio, it would allow me to increase that time frame up to almost about 30-ish minutes, maybe a little bit more. We're kind of looking into that a little bit, that I can spend on doing that whole process. And then that would even allow me to work in care plan meetings with families who would like to sit, meet, and go through meds. That's a direction that I would like to go. I haven't gone there yet, but that's kind of the direction I'd like to go, to kind of make sure the medications are aligning. I'm a less is more. Like, let's just be on what we need to be on, but then also taking care of our patient at the same time. I'm one not to want to suffer or be without medications if they are necessary. So that is something to also make sure you're weighing in. So I'm working on a model to help incorporate that, and it's across the spectrum. So you have to kind of get involved, like your nursing staff, floor nurses, administrators, directors of nursing, your medical physicians. I work with dietitians, and then different specialty groups that kind of come into facilities. So it's like psych. There's a lot of psych groups that go into facilities. So working with psych groups. Wound care, psych groups, wound care usually visit facilities and some of those different providers. So it's a lot of a communication and an education piece on how I can kind of insert and incorporate myself to be a valued member of that team, and to see how I can assist. And every facility is different based on like their strengths and weaknesses. So kind of building that into your model. I want to eventually get into the aging in place and home care, but the issue that I ran into when doing some of the insurance, and I've mentioned this before, is it's a different language. And it's something brand new that I've had to learn and teach myself. And anytime you're dealing with some things with the insurance companies, you'll find that's a hurry up and wait. So you'll do a bunch of stuff, and then you gotta wait 2 to 4 weeks or so. So it's like a sprint, and then you stop dead in your tracks for a little while. So it's been a slow, long process, but it's been fun. I've learned a whole lot. I've met a lot of fun and interesting people along the way. And if I'm able to bill for this model, I'm looking to see how I then can incorporate into like a long-term care at home, whether it be home visits or I don't even know all the different ways I can get into. I have a couple of people I'm going to reach out to see how I can make this kind of push and go. But can't put the cart in front of the horse, so I got to start somewhere. And I figure this might be a way to go, and then you can always make the model kind of work for what you need it to be.
So, go ahead, Kevin.
No, please. I was going to switch subjects. So Donna,
Yeah.
you
I'm just curious about one thing. So going back to the long-term care model as it stands now, and thinking about it, and I know that there's this every 30-day review that's being done that maybe people don't realize. So every 30 days, if your loved one is in a long-term care facility, then they are actually being reviewed by a clinical pharmacist. But like you're saying, it's so short, and you may or may not be seeing the patient. You may or may not be seeing the provider that needs to make the change too. So a lot of it's notes, like back,
Mhm.
etc. But there's only like so much change that can happen. Do you feel that you're able, just in general, and I know it's an opinion, are you able to make progress to the point, like, do you almost have a plan for this patient? Like, okay, this patient's on 20 meds and I really want to get off of, this is my big picture plan for them as their clinical pharmacist, but I know like I have to, see how they do. Are you allowed or are you able to make that happen, is what I'm trying to say, with how you approach your patients?
So yes and no.
Hmm.
So in some of them, you can. You have really good access to like the electronic health record, progress notes, and all the information, but it depends on what access you have to and who you can speak with to be able to make up those specific clinical plans. Oftentimes, when you're going through facilities, each month I'll have like a specific goal of something that I might be looking at. Like I have like my standard subset of things I'm looking for. Did anything change from the last month? Are there any new presenting symptoms that were documented or that I spoke with staff that a patient has experienced? So I have like my little mini checklist, but I'll have like a goal or a target or a focus each month on top of that I'll kind of look at. So what would be an example? So I might look at anticoagulant medications in all my residents. Are they dosed appropriately based on your renal function and with the appropriate indication? If not, are we checking and monitoring for things that's surrounding this medication? 1 month I'll check out your diabetic residents. A lot of times hypoglycemic unawareness, so low blood sugar, you're not feeling any symptoms, happens a lot in long-term care facilities. So I might make that being a target. I often check that anyways as part of my routine look at. But I'll try and make some of these little snippets or combinations. Like if you see certain medications that might be high risk, something that we hear that we're like, hey, we hear this is coming up or this changed in the med world. Do we have any patients on this? So we'll often pick like different targets, deprescribing opportunities, looking at as needed medications. Are they really necessary? Or if you have people that are on these absurdly long med lists, can we shorten that up? Because it's not only is it like daunting to look at, some people might actually need that, but it always raises a red flag of, is there something we can take off? Because that's a lot. A lot of times in those residents, they're not eating. It almost seems like their meals are their medications.
Yeah, that pill burden conversation is one that I'm really curious when you start dissecting an individual facility and looking at the patients that you're going to have, like on here's the next month load of patients, and you've got some with 3 medications and some with 30 medications.
If they had 3 medications, I would be doing a happy dance. That is very rare.
I have seen a couple that are on that only for a couple weeks, and then all of a sudden we're throwing them on every medication under the sun. But with that being said, all jokes aside, I was just having a conversation recently about digital therapeutics and how we're going to start using different applications and software to be able to help people with their disease states, right, overall. And the conversation kind of went toward clinicians not feeling, so usually nurse practitioners, PAs, MDs, DOs, etc., not feeling comfortable with knowing that new technology, right, how it goes in place. And when I asked a question related to their overall comfort level with medications and physical therapy, one of the clinicians said, well, I'm not comfortable with physical therapy because there's a lot of nuance to it. And it made me chuckle inside, like thinking about the amount of nuance that there is to medications that we often miss. And that's why we have so many problems later on. Well, what happens with you, Courtney, when it comes to the other side of the med list, which in my mind is the monitoring list? How do you help us to be able to look at, in a very taxed long-term care setting, be able to plug the monitoring parameters that are necessary to make sure these drugs are working, not hurting, and benefiting those individuals, so you can lay it out for the long-term care facility to be able to make progress?
So it's a big challenge if you're factoring in the time. If I'm given all the time, it becomes much easier, which is why I'm on my push to push for doing what I'm doing, because that is the right question.
So Right?
the current model, yeah, you bring up a very good point, and it's something that's super challenging for us. Some of the things that you can do is when you're doing something like your labs and monitoring parameters, in my software, I have the capability to track labs. So I track labs over time. So for some of those medications, they're very lab focused, lab based, lab heavy, like some of your diabetes medications. If their A1Cs start dropping below a certain level based on their level of care that they need, I start pulling back on some of those because I don't want people to get too low blood sugar and then start falling. So that's like a simple thing to kind of start looking at. And when you start looking at like blood pressures and some of those types of medications, you can track that pretty easily with your blood pressures, heart rates, and labs. Some of those are a lot easier. When it comes to long-term care, they have a set of codes and standards they have to meet called the MDS, the minimum data set, that helps build the picture of the resident in a systematic, standardized process. So with some of those medications, you can look at that MDS assessment and kind of make some generalizations or assumptions if you don't have the time to meet with your residents and physicians, start asking some of those questions. When I start writing up some of my recommendations and my reports, I have a tendency to ask the questions as to not ask the question, and then leave it up to the physician or the provider to then do a full evaluation and pull things off. So ultimately, I leave it up to them to see what they think, but just based on my professional opinion and what I'm seeing and how some of these goals of care align with what the facility's documenting versus what's actually on their medication list, to see if there's an alignment or a misalignment or if we're missing information. Because oftentimes you'll notice that as people transition through care, a lot of the information from the past is lost. And when I start asking questions, the physicians or some of the other providers say, "Great question. I don't know because that information is not at the facility." So then you start getting into, and this is where I kind of get into like indications for medications, especially some of the ones that are seems like the recommendations change, like aspirin.
Yep.
Everybody's on aspirin and the recommendation just changed.
Yeah.
And so what does this person have? And then I get some blank stares. It's like, do we really need this? And then I get more blank stares. And I'm like, well, it's not hurting them, so let's just keep them on it.
Mm-hmm.
So those are the conversations you start having.
So where's that proactive approach, right? Like that, it might not be hurting them right now.
Yes.
Yes.
And that's what I bring up. I'm like, well, if they don't need it, why are they on it? Do we have
Can we
to?
be proactive like you were proactive putting them on aspirin when it was recommended?
Yeah.
Now it's not. So can we be proactive with not having it on board?
Mm-hmm. And that's when I start having a lot of those conversations.
Yeah.
Same thing with my PPIs. It's aspirin and PPIs right now. That's what I'm dealing with. And long-term statins when our LDLs are really low.
Yeah.
And they're not like non-existent.
Yeah.
So those are my big 3 drugs right now that I'm my current conversations.
So just if we can have just a little bit more of a conversation on this. So in what I'm trying to have students help me with is doing some of the research. You know, how low is too low for cholesterol? Is there a too low? And starting to ask those questions and where might we be able to find some of this information. The other thing I find difficult because I'm on the hospital side of things. So people from long-term care or, you know, even being at home and being cared for by loved ones end up in the hospital. And then, you know, of course, big long list too. So what could have caused them to be in the hospital? But also with the changing of actual guidelines. And what I find is things like COPD. And which inhalers should they be on now? Because that has shifted too.
And do you remember what he was even in those combination products?
So I know exactly. So doing all of that, and then you know, oh no, they need the triple therapy. Well, no, they really don't need the triple therapy anymore. And you know, so there's a lot of those things that are shifting. And I often wonder, you know, so are we shifting away? And how willing are people able to do that? But then, you know, with heart failure, which is another big issue for people in long-term care and also coming to the hospital, is this new 4 pillars of treatment, and how aggressive should we be, and can people even afford it? So I think we get into so many different things, and I think that brings us all the way back to, you know, what does the patient want too? And what do the families want? And what are we looking for? So a delicate balance for sure. And
Yes.
it's hard to make those recommendations. And I can see where providers who are writing the prescriptions too are maybe going, I'm not going to touch anything right now.
And that's where I like to have those conversations. I like to, the patients that I'm able to meet with their families, like, these are the options that I have. And I like to be upfront and straightforward. These are the options we have. This is what clinical guidelines say. This is how I think this could align. This is where you could be. Like, what do you feel? I always like to bring it back to the families and the patients. Like, does this work for you? Does this not work for you? Does this work for your life? If not, and I even do like, I have had like families call me back like, hey, here's my number. If this doesn't work, or you feel like this could be better, we can change it. We can customize it to you. Because what I run into is then you run into the adherence issue. If you can't afford it, if you can't do it, if you don't understand it, if it's too confusing, I like to look at it as something is better than nothing. So if I can't hit that standard, but I can get you a little bit closer to it, then that's better than you just kind of completely giving up and saying it's not even worth it.
I agree.
So I like to try and meet people where they are and what they're comfortable with.
Yeah.
That
Singing our song.
What's that?
I said you're singing our song.
Oh, I know. I preach. Tell the insurance companies. I hope they're listening.
I tried. I put them in there. I put them in the notes that they need to listen.
Oh, good. So I think that buy-in, insurance companies aside, but the buy-in from families and from clinicians is one piece. But I think the other element that we sometimes forget in the long-term care conversation, Courtney, that I'd love to hear your thoughts on is a lot of times these facilities are being basically run by a single nurse and a number of MAs that are working with them. And they've got a lot of pressure on them to be able to take care of X number of patients. What's one thing for families and for clinicians to realize that are some things that they need to be able to help this short staff group out to be more successful with their individual patients?
If they feel like the goals of care aren't aligning, make sure you say something. If you notice something's off with your loved one, you know them better than your loved one better than anybody caring at the facility because you've been around them for how many years. So if you know something's off or something's different, speak up.
Who to?
You could speak up to, if you tell like nursing staff, there's a reporting system that they can talk to you. If you have a meeting with a physician, you can do it that way. If you care conferences, care planning, a lot of times those are required in your care conferences and care planning. So you can bring that up with them. There is a whole like regulatory piece of knowing what the rights of your residents, what your patients are in your facility are, so you can easily access that, because the long-term care sector, and this excludes like assisted living and some of those other ones because that's very nuanced depending upon like the state you're in. But I'm talking strictly long-term care and skilled centers. There are ways to kind of go about the process of going up the chain and figuring out like who the right person is. And each facility is a little bit different. So depending upon the size of the facility and how it's structured and set up, but there's certain requirements and standards they are required to meet. Assisted living is very different. If you're more of an independent living, that's a little bit different. So you'd have to really kind of go out on your own. And that's kind of where I would like to also dive into for your, long-term care at home, because that would fall into those realms. But you'd have to, talking to the nursing staff that's there working the floor with your loved one at the nursing station, physician, and then your care conferences, or care plans.
The one.
Did I answer your question?
Yeah, because they're state regulated too. I believe that, there are standard phone numbers too in the state that you can actually work towards. So if they're, if you're uncertain, I think that there's structures even within the state that you can learn from as well.
You have like the Alliance Area on Aging. If you ever have questions, they're usually a good resource for the aging population. And I don't know if every state's set up differently, but in Ohio, it's usually regionally based. So you find the regional center or the local center that you can kind of go through to see what your options are as well.
The only plug that I'll throw in there, Courtney, when it comes to easing things for both the patient and the clinician, right? When it comes to the taxing of the nursing staff, a couple easy things for folks that are listening to be able to understand clinician or patient side is the more frequent we dose throughout a day, the more pressure we put on our staff and the more pressure we put on our patient's body to be able to handle medications being given once or twice a day versus 5 times a day. And so simplifying that overall to make it a more coordinated effort for med pass as opposed to putting more pressure on multiple med passes, huge win. The other one for your family to be able to look out for, even though it seems like it's a very effective way to go about things and kind of a trial and error process, a lot of med errors and a lot of adherence issues are due to PRN medications. And so if there is a way for us to be able to dial down on those individual medications that are given every once in a while or as needed, so to speak, depending on the staff member that's in-house, how they're evaluating the loved one or the patient, those variations can also cause some issues. So those are the only last plugins I have with your answer there, Courtney.
Another thing to add to that is a lot of these facilities are contracted with in-house pharmacies, and you have the choice to use whatever pharmacy you choose. But one nice perk is when you use the dispensing pharmacy that's contracted with the facilities, oftentimes they have specialized packaging and there's specialized requirements. So something to also consider because then that also reduces like your med errors when you're talking about your med errors, because sometimes they can do like the unit doses, which I like. The unit doses is when they can kind of check through those.
Beautiful. Don, any last questions for Courtney?
Yeah, I just want to like look towards the future a little bit, Courtney. And we talked about your successes and what you're working towards. If you could, have your own way, what would you hope to be the future of clinical pharmacy in your area of expertise?
I want to be able to function as an independent provider to provide value information to my patients and help them. I want to be able to help them the way that they want to be helped. So a lot of what I do is like education, living in their own, aging the way that they want to age. I've even had these conversations with my parents and my in-laws already. Things to consider, and then being like almost, I don't want to say like a clinical care coordinator, but some of my role is helping coordinate care when I have to reach out to specialists to figure out and solve medication related problems, and identifying some of those tools and resources with like medication lists and maybe pointing people in the right direction of things to consider. So I like to work on an interdisciplinary team with other providers along myself to provide that medication therapy management piece. But I also want to be able to function and bill independently.
Couldn't agree more.
I love that. I think the only thing that I need Donna to do is take a drink from that awesome cup that you have there.
Yes.
And one good way to educate people at home right there is a fantastic book. I really think that's one piece, Courtney, that oftentimes gets missed is a family member goes, how do I learn about how my medications for mom or dad are getting managed? And as you and I mentioned, 3 medications is basically impossible. You're looking at 20, 30 medications for a lot of folks. And it becomes really overwhelming. So having some educational tools in place, like a book, workbook, educational resources online, can be a huge advantage for families trying to do something like this. And the other piece, I feel like it gets looked over, but the medication experts for your family are their pharmacists, right? And so that ends up being something that is a great resource for family members to lean on that I had at my long-term care facilities. They were able to schedule meetings with me, so that we could go over medications or we were pulled into the care plan meeting. So I'm so glad that you're really pushing the envelope and getting yourself connected on that care coordinator level. It's just really huge. Any last things for our audience, Courtney? You want to make sure that they...
No, I just want to thank you both for your time. And I really had a lot of fun.
Thanks. We did too. And Courtney, as you're building your business, make certain you get workbooks in all of your residents and caregivers' hands.
Thank you.
Love it. But I just want to say to our audience to Please listen and subscribe, share, review, and repeat. We're here on Mondays at 6 p.m. Eastern Time and 3 p.m. Pacific Time. So we love when you can join us. So thank you so much.
Perfect. Yeah, thanks so much, Courtney. Really appreciate you. Like, subscribe, share all that good stuff to be able to pass some of these really amazing pharmacists, clinicians, patient caregivers all around so we can get a little bit informed about the med list. Hope to see you guys next week.